Welcome back, everyone, to Einstein's Eyes, our YouTube channel. Jon and I are partners and co-creators. We are ophthalmologists. I'm an oculoplastic surgeon in Anchorage, Alaska, and Jon's cornea and anterior segment. We both trained at Albert Einstein Montefiore Medical Center years ago. And we have a special guest today, Dr. Angioletti, a retina specialist, who's going to talk about treatment of posterior vitreous detachments and floaters. Now, you might recall that we did a video on this topic, or these topics, but we didn't talk about treatment specifically. So
I would just add a couple of things before Lee gets to talk. So Lee's a retina specialist, vitreoretinal surgeon in New Jersey, and also practice in New York, Lee, or no?
I used to. I mean,
Yeah,
before I was at, as a professor in New York, Ioneer,
Right.
obviously trained there, went to Atlanta, trained for a year, came back, joined practice with my uncle, my brother. And ever since I moved to New Jersey, I was at New York Ioneer for like 25 years. So now I just exclusively, I was in New York and New Jersey. Now I'm just in New Jersey.
Right. And yeah, trained at New York Ioneer, did your fellowship in Georgia, right, Atlanta?
Yeah, in Atlanta.
And so obviously has many years of experience with various retinal problems, both surgical and medical. We're lucky he works in our office one day a week, but he also works in his own practice and other places. But I just would add, so when we talked about the floaters, we were really talking about what it means. But I think what this video really wants to center on is these annoying floaters, these people that come to me or to any of us, and they'll say, I'm really bothered. Like, I can't get rid of this, and it's really annoying. What can I do about it? Right. And what do I do with these patients? I send them to Lee, which is really nice for me. But that's why we want to hear what he tells those patients.
Yeah, I mean, so basically, you're absolutely right. I mean, most patients I see, they're usually told there's nothing can be done. I mean, whether it be from the referring doctor or they went somewhere else, and they're actually surprised to say something can be done. I say something can be done, but you're probably not going to like it because it requires surgery. And as you probably know, drops have been attempted. There's also some controversy using these YAG lasers. I know they do a lot of them in Florida. If you want to make one floater into two, I guess you could do that. But you have to be careful what the floater is. If it's close to the retina, you could cause some harm there. But it's to do vitrectomy. We thought about like, well, that's malpractice. That's being very aggressive. Back in the day when we were doing 20 gauge vitrectomy, and I guess for the layperson, 20 gauge means the size of the actual instrument. It was pretty large. And we used to make these openings in the eye. We used to make 3 openings called a vitrectomy, one for the probe to suck the floaters out or the vitreous jelly out, one to put a light in the eye, and one to put an infusion in the eye. But these openings were relatively large. You had to cut down the conjunctiva. You had to sew up the sclerotomies. Vitreous can get incarcerated, and then the retina could detach and get tears. So it was a lot to do. The surgery obviously back then was more complex, was more so-called barbaric. Now we have these small gauge vitrectomies. I mean, we're not making, we're not doing peritomies. We don't even have to close the sclerotomies. So we're having less risks of retinal tears. And it's more of an elegant surgery now, and it's done a lot quicker and safer. So it's being offered, and I got to tell you, I have like 100% of the patients who have end up getting vitrectomy for floaters are quite happy because they're either told there's nothing to be done and to keep waiting. Personally, I have phakic patients. That's patients who still have their lens in their eye. I tell them wait at least 6 months. And I said, if it still bothers you at 6 months, it is going to be surgery. We could talk about it. And those patients that come back want surgery. And as long as they understand the inherent complications, that being vitreous hemorrhage, retinal detachment, endophthalmitis, and most likely to develop a cataract, we could talk about how to prevent that. Most of them understand that, and they're willing to go through the surgery. Pseudophakic patients who've had cataract surgery, I'll wait about 3 months for those patients because obviously I can't get a cataract. But obviously the inherent risks are still there in pseudophakic patients as well. But I would say that most patients are actually relieved because they're shocked that something can be done. But most of them are not willing to do the surgery right then because first of all, they're shocked that something can be done, obviously the vitrectomy. And like I said, it's like 100% of these patients are quite happy, and whether they get a cataract or not. But you know, we could talk about the surgery itself and you know what we do nowadays, and to try to prevent the cataract or reduce the risk of the cataract and other complications like type 1 retinas that we had more commonly associated with the 20 gauge vitrectomies.
Lee, let
Yeah,
me
so
jump in.
to clarify for the viewers, so
Mhm.
when you do a vitrectomy for these patients in particular, let's say, so you're using an instrument that's very small, correct?
Correct.
Much smaller than before, and you don't need to do a conjunctival anything. You just go right through the conj, or how do you do
Go
that?
right through the conj. We make a little beveled incision, angled incision, so they're self-sealing. There could be
So
still
that's a
some
big
vitreous
difference.
incarceration. I'm sorry.
Big difference for the patients afterwards, after surgery. Their
Oh
eyes
yeah, I mean
inflamed.
it's unbelievable. I mean sometimes I see these patients post-op and I turn to my scribe and like, which eye do we do? Because you
Really?
literally, oh yeah, I mean sometimes you don't, I mean if you don't get a subconjunctival hemorrhage,
Right.
it's sometimes really difficult to see which eye you actually operated on. Unlike
Right.
back in the
So it's
day,
pretty
you
quiet.
obviously
So it's pretty quiet. That's
you're
good to
putting
hear.
sutures in the eye, you're closing the sclerotomies, the eye gets inflamed, it hurts. You know, maybe some induced astigmatism from the sclerotomies themselves.
So I definitely want to talk about the cataract, but let's say it's a pseudophakic patient. So again, for our viewers,
Sure.
someone who already had cataract surgery. So we're not worried about causing a cataract. So in that setting, so you have a 70-year-old person really bothered by a floater. First question I have is, does it matter to you if it's a PVD or a vitreous floater? Does it make a difference?
No, it doesn't.
Okay.
It doesn't. But that's a great question because I mean, and again, just to talk about, because I was going to talk about with the surgery, one of the inherent risks is obviously a retinal detachment. So having a PVD prior to the surgery is nice because it makes the surgery a lot easier. I mean, inducing PVDs, typically in a 70-year-old, it's not that difficult.
Probably already had it.
But
Yeah.
I actually just had recently a nurse, 20 years old, not going to work because he was so bothered by the floater. And I had him get a second opinion. I say, I'm not touching your eye until you get a second opinion because you're not operating on a 20-year-old phakic patient. But he was so symptomatic, the guy was not going to work anymore from his floaters. And, you know, I had him get a second opinion. Doing a PVD, and that's, and again, I know you guys discussed what a PVD is, but a lot of these young patients don't have a vitreous separation. And it's a very, very difficult maneuver in a young patient. It's quite adherent. And you're sucking vitreous over the nerve, over the macula, you can cause some major problems. But I was successful, but you know, that's a little controversial because we could get into that because actually the safest thing to do is don't actually do a vitreous separation. Actually keep the vitreous intact because that's 30% of patients typically. I don't see that high, but in the literature, it's like 30% chance of developing a retinal tear from an induced vitreous separation. And the other thing to prevent cataract, when we talk about that, is actually keeping a cushion of vitreous behind the lens. Because I forget if you guys discussed what actually causes a cataract or theoretically causes a cataract.
We didn't really get it. I mean, we talked in general about cataracts, not from this procedure or anything like that.
Yeah, so by removing the vitreous, and it's kind of like what happens with a senile cataract, is as we get older, the vitreous gets liquefied. So what happens, the oxygen from the vessels, which is at an altered state, right, free radicals, causes the lens to mature. I mean, this is hypothetical, but that's basically what happens. So now by removing the vitreous jelly, you're removing that cushion between the retinal vessels and the lens, and that's going to cause a lens-induced cataract. So by keeping the vitreous, the anterior hyaloid, that's what we call it medically, behind the lens itself, you actually are allowing some of a cushion between the lens, obviously, and the vessels to theoretically reduce the risk of developing a cataract. That's not going to be zero, but it does dramatically reduce the risk of the patients getting a cataract. But you're leaving some vitreous behind, and you also, if you're not inducing a PVD, what can potentially happen? The PVD happens, and they got another floater, so you potentially may have to go back in. I particularly like to do a PVD, even in the younger patients, because these patients are complaining of floater, and then they get a PVD. It's like you got to go back in, you know.
That'd be terrible.
Now, granted, if I cannot do the vitreous separation, I do multiple maneuvers. I would say, listen, I'll tailor this. I had to abort the case, and we may have to come back because it is one of the riskier part of the procedures is inducing a PVD and potentially leading to retinal detachments and other complications. So they're aware of that. You know,
so it sounds to me like if someone already had cataract surgery, they're bothered by a PVD, that's almost a slam dunk for you. I mean, yeah. So I mean, obviously, you still have to go through the risks and benefits, but And then a little bit more risky, of course, is the younger person with a PVD. And then even more risky would be someone who hasn't had their vitreous separation yet, and they
Sure.
don't have a cataract. So you have to kind of deal with that part.
Correct. And that's why I delay it, just because by delaying it, you're allowing the vitreous syneresis, the Weiss ring. I don't know if you guys discussed the Weiss ring, which is that adherent vitreous on top of the optic nerve, and they get that circle, the crescent. That breaks up over time because it's part of the vitreous syneresis. And most patients, you guys know this, eventually it does break up in most of the patients. But when they did the study, I think there was a study in the Retina Journal, like I don't know, the early mid 2000s. I think they waited 2 years to do these cases, and the patients were bothered for 2 years. I don't have patients wait 2 years. 6 months seems to be pretty standard, I would say, and I would say over 95% of the patients don't even come back because they're like, oh yeah, I got better, but I still wanted you to take a look at it. Maybe 1% of those patients end up needing surgery.
My experience is for sure. I mean, I've always gone with a year, but it's good we're talking, considering we work in the same office, right?
Yeah.
But I think, my experience has been, I tell people to wait a year, and most of them, as you said, when they get to a year, they're not as bothered. They learn to tune it out. They've learned their brain and their eye.
They're neuroadaptive.
But you definitely have the people that no matter what, I mean, you wait 6 months or a year, they're miserable. They're really bothered. It's in their way.
Well, you're a cataract surgeon. I mean, basically, it's reduction in contrast sensitivity, right? I mean, their acuity can be 20/20, 20/25, but it actually reduces. There's actually a visual. They actually had when they did these studies, they actually had questionnaires, and it came down to the contrast sensitivity, which, as you know, is significant for the quality of the vision, not necessarily the acuity, but the actual quality of the vision. These patients are really, really bothered by it, and that's why when they come to me and they said, "Oh, I was told nothing can be done," I'm like, I could definitely offer you surgery, but these are the risk factors and cataract. And when it comes out, they're so relieved.
How often have you seen either like a retinal detachment or epiretinal membrane, something that affected their vision afterwards?
Jon, I really cannot.
It's pretty
remember.
Rare.
I mean, you read it. It was funny because when I read, I think you had brought up 10 to 15% of PVDs have a tear. I think actually the vitreous hemorrhage is up to 50%. Wow. I don't see that. I just don't see that in practice.
And I don't see.
I've been doing this for 35 years.
When Carl and I first talked about a PVD and the incidence of retinal tears, I think it's extremely low. I don't think it's close to 10 to 15 in my own.
I don't think you're absolutely right. I totally agree with you. And I don't know where to get.
We actually talked about it. That the statistics, and you read it. You could look it up on your Google in a second. You get that 10 to 15%.
Yeah.
Well, I haven't seen that. I've seen like very low percentage.
Yeah, I think with the hemorrhage, though, with the hemorrhage, you do want to look around. You do want to do a dilated exam.
Sure.
Lee, what to drill down for patients listening on the channel, how long does it take typically, and where do you do it, and do they have to go to sleep?
They don't have to. I almost never put any of my patients to sleep except for the retrobulbar anesthetic, which is we give a local under the eye here. Unlike the cataract surgeons, just use topical. But I use actually peribubble now. So they're asleep for that, and then they wake up in the OR, and they're basically very relaxed. Have an anesthesiologist there. Occasionally, I'll put them out if I'm doing some macular work, or if I'm doing a PVD. If I have to do a PVD and I think the patient is talking too much, but I typically like them awake because I don't want them snoring, or I don't want them waking up when my instruments are literally over their optic nerve. So we keep them in a very relaxed state. The surgery itself, 15 minutes. If they have to have a PVD and remove PVD induced, maybe 20 minutes. That's pretty much it. That's standard. Again, because you don't have to do a peritomy. You don't have to close the conjunctiva. Occasionally, I'll close the sclerotomies. I usually don't. I guess what I do a little different than some of my colleagues, I actually tend to put a bubble in the eye. So, patients, do I have to put face down because I can't fly in an airplane, because that's typically they're probably reading about patients with retinal detachments, macular holes. They have to be in special positioning. I literally use the physics of what keeps an air bubble an air bubble. It's the hydrogen bonds, and that will tamponade the two sclerotomies superiorly to prevent some egress of fluid at the end of the case. So I don't necessarily have to close the sclerotomies. Of course, I check to make sure they're not actively leaking, but typically the hydrogen bonds of the air bubble will tamponade the sclerotomy so they don't leak if the patient doesn't get a hypotenuse. Also, I like the eye to be filled up with air at the end to ensure I got all the floaters, because sometimes you go in there and you just leave fluid in there, but there's actually some vitreous membranes that are left behind. You just can't see it.
Right.
So I usually tell a patient, I will fill your eye out with air. I might put a little fluid back, but I usually like to keep the eye filled with air for the true reason. So ensure I got all the floaters out, because floaters cannot get inside the air bubble. And also to keep the eye from getting hypotenuse and not necessarily needing sutures.
And where do you do it?
I do it at a surgical facility, in and out. I mean, you get done in a hospital too, but I typically operate at, like Jon, one of these,
Surgery center. Yeah.
surgical centers. Yeah.
Great.
And insurance covers it, right? I mean, there's no
Yeah.
issue.
Yeah. I
Yep.
mean, it's, like I said, it's like a floating cataract. I mean, we the studies have been shown that these patients have, it's like a PSC cataract, right? You could be 20/20, 20/25,
Oh,
but
yeah. But
the
it's moving
quality
it.
is terrible. I mean, certain times of the day. I mean, a patient could be blind driving at night from a PSC cataract, despite the fact that 20/25. So yeah, it's covered by insurance.
Great, great.
And laser, I mean, in your opinion, have you ever done it? Do you have any?
I have not done it. I've read about it. For some reason, there's a lot of guys down in Florida doing it. There is one of my colleagues actually is in New Jersey who had a laser. I spent a year with him. I never saw him use it. But it's controversial in terms of its use. And like I said, this, from what I understand, there's no peer review that shows that actually it's
Yeah.
efficacy.
That's, I mean, I remember looking into it a few years back, and but then I've had some patients have it done other places and they said it helped them.
But Jon, you know what? You could give them Sustain, and they're going to think that's going to help them too,
Right,
because
that's
over
true.
time the vitreous syneresis kicks in,
True.
right? So a lot of these patients are going to get better anyway. So if they said they had the laser, they're going to think the laser caused it. We're like, no, time did it, and just the natural syneresis of the jelly.
Yeah,
Right.
that's a good
The Academy does not recommend it. If you look at aao.org, when you read the wiki on PVDs and treatment, they suggest not to do it, but
Not to do laser, or not to do vitrectomy, or not to do it.
not to do treatment.
Wow.
Oh, no.
Interesting.
Not even do vitrectomies. Interesting.
Seems like they've got to really update that. I mean, based
Yeah.
on,
That
Yeah.
that might be true. That might be true. Right,
Yeah.
right. That's the latest what I saw. But
Yeah.
anyway, Lee, thank you. Jon, thank
Oh, my
you.
pleasure.
Hit it out of
yeah,
the
Lee, that
park.
was great. Very informative.
Right.
Yeah, great. Thanks, guys.
Yeah, we're gonna have you back on here for another topic.
Well, Carl's coming to New Jersey. When you coming to New Jersey, Carl?
I am coming as soon as I get the dogs fed and I get the
You
sled.
got to get your
out-
sled. You got to get
out
your
of
sled
the-
going out there.
Right, out of the barn. I gotta get that tuned up.
Bring some fresh salmon.
Oh yeah.
Salmon.
That's
Nothing like
have.
Alaskan salmon.
Absolutely, absolutely. I'll bring
You
the
missed our
aroma.
last video. I was asking Carl, what's more difficult to get? A special eye drop for your eye, Vital Tears, which is the autologous serum drops, or a slice of pizza in Anchorage. And it was clear that it was easier to get Vital Tears, right, Carl?
Absolutely. No. Listen, we're tough, we're hardy up here. We eat what we kill. All right.
Well, enjoy
Thanks,
the
guys.
night.
All right, man. Have a good night, guys.
See you
Thanks
on
to
the next
everyone
one.
for tuning in.
Like and subscribe.
Thank you.